The ovarian cycle lasts approximately 28 days, but that varies quite a bit. Only 10 to 15% of females have a 28-day cycle. It can be 21 all the way up to 40, but that's just an average of 28 days. The events that define the ovarian cycle occur in two phases, with ovulation that you can see right here, splitting the two phases right in half. So ovulation ends one phase but begins the next phase. So you have the follicular phase in blue and the luteal phase in green here. So the follicular phase is the growth of the follicle. And we can see here all these follicles. One becomes the dominant follicle, and there is ovulation. So that lasts approximately 14 of the 28 days, so half the cycle. After ovulation, we get the luteal phase, and that's the period of corpus luteum activity. So here it is. The ovulation has occurred. We're left with the corpus luteum, and 14 days later, if there's no pregnancy, it degenerates. Now, we mentioned that this 28 days varies, but that variation occurs in the follicular phase. So the follicular phase can be less or more than 14 days. And that's significant because the luteal phase, right there, luteal phase is always 14 days. So this 14 days does not change from individual to individual. That's because we need time for a possible embryo, which is what a fertilized egg will become, an embryo, to implant in the lining of the uterus. That can't happen unless you have this 2-week period to prepare for it, because if the lining is shed in menstruation, then the embryo will not persist. So when we're looking at these two phases, just remember that the follicular phase, time can vary, but not the luteal phase. It's always 14 days. So here is our HPG axis again with hormone release. So there's our hypothalamus, which is going to secrete the gonadotropin releasing hormone to the anterior pituitary, and the anterior pituitary secretes our FSH and LH, luteinizing hormone. So the FSH, called follicle stimulating hormone, because that's what it does, it stimulates the follicle to grow, and this is in the antral phase, so it does have an effect. You can see the antrum of fluid in there. So FSH stimulates growth of the follicle, and luteinizing hormone LH will act on the thecal cells, causing them to release androgens, while these granulosa cells convert the androgens to estrogen and also release inhibin. So estrogens and inhibin will act as negative feedback chemicals back at the pituitary and the hypothalamus, thereby producing less follicle-stimulating hormone. Now, this right here is the dominant follicle. So when FSH levels drop because of this negative feedback, this is the only one that's able to survive the dip in FSH, because the dominant follicle outcompetes the other follicles and is the only one to continue on. So this will complete meiosis 1 and become the ovulated oocyte, where all the other follicles cannot survive this dip in FSH, so the non-dominant follicles will then undergo atresia. So now we've completed half of the follicular phase. So we went through early to mid follicular phase. We're going to move on to the late part of the follicular phase and then the luteal phase in this part of the figure right here. So here's our mature follicle. There's the large antrum right now. So in late follicular phase, this selected mature follicle is going to be secreting a ton of estrogen. You can see all those arrows. This huge increase in estrogen is actually going to have a positive feedback effect on the hypothalamus and on the anterior pituitary. So we get this surge of luteinizing hormone. And the surge of luteinizing hormone is going to cause the follicle to rupture and release the secondary oocyte. And that's, of course, called ovulation. And that's where the luteal phase begins, right at ovulation, like we saw from the previous figure. And what's left over from the ruptured follicle becomes the corpus luteum. That's why we call it the luteinizing hormone, because it creates the corpus luteum, which then becomes an endocrine structure, because its job is going to secrete hormones like progesterone and estrogen and inhibin, but these hormones are now going to inhibit the pituitary and the hypothalamus to stop this LH surge, because we no longer need this area to occur. But what's important now are these hormones of the corpus luteum to help prepare the uterine wall for a possible fertilized egg. So, just to recap here, that positive feedback is exerted here because of the large increase in estrogen, which would cause more luteinizing hormone for ovulation, but then the corpus luteum becomes an endocrine gland or endocrine structure. And now this estrogen and progesterone, we can see they're in specific amounts, will actually become or act as negative feedback chemicals to end this process, but to maintain the uterus. So here we're looking at hormone levels. In the first graph here, we're looking at the gonadotropin, the LH and the FSH, and we see the follicular phase and the luteal phase in green here. And you can notice at the end of the luteal phase, just beginning the follicular phase, we get that rise in FSH and LH, and of course FSH, follicle stimulating hormone, that slight rise up through here is what helps develop that follicle that has the antrum, and it keeps growing, and then we could just see that declining level of FSH because of the inhibition that we saw on the previous slide. But the reason why we get these large spikes here right at ovulation is because of that surge in estrogen that we saw from the previous slide. Again, that surge in estrogen causes this positive feedback that we saw, and there's our luteinizing hormone, which causes the ovulation. That's why we go from blue to green, follicular to luteal phase, and we see the FSH actually surges slightly as well. Now down here we see estrogen and progesterone. Of course, we get that surge in estrogen, and then after ovulation we get the drop-off, and progesterone as well in green. In this, we see that in this chart here. But what's happening is after ovulation, we have the corpus luteum that secretes estrogen and progesterone, so we get these rising levels to maintain, and what's important with these hormones is to maintain the endometrium, which is the inner lining of the uterus to support pregnancy. And of course, if there is no pregnancy, well, those levels will just eventually drop off as the corpus luteum degenerates. So ovulation, as we know, is when the ovary wall ruptures, expels the secondary oocyte. It has a corona radiata, which is a radiating crown. Those are the surrounding granulosa cells, some of them that are expelled with it. Looks like it has this radiating crown. It gets expelled, the oocyte, into the peritoneal cavity, of course with the goal of going into the uterine tube. Mittelschmerz is pain felt sometimes by females during ovulation of that ovary wall rupturing, sometimes some inflammation in the peritoneal cavity at the same time. Funny name, Mittelschmerz. 1 to 2%, so a small percentage of ovulations actually release more than one secondary oocyte. And well, what happens if both of those oocytes get fertilized? Well, they would be twins, but they would be fraternal twins because there's two different eggs and two different sperm fertilizing a different egg, which means they are not genetically the same. So fraternal twins are not identical twins, they'd just be siblings born at pretty much the same time. Identical twins is when you have one sperm fertilizing one oocyte, and then after fertilization, they can separate into daughter cells, which are genetically identical. So just a kind of a different process, fraternal versus identical. In some women, oocytes may be released at times unrelated to hormone levels, and that would be a cause of infertility because we need those correct hormone levels to maintain the inner lining of the uterus for pregnancy. So after ovulation, there's ovulation right there. The granulosa cells and internal thecal cells, they enlarge and they form the corpus luteum, as we already know, which secretes progesterone and estrogen. If there's no pregnancy, so there's the secondary oocyte, if it does not become fertilized, then the corpus luteum will degenerate into something called the corpus albicans, a scar, within about 10 days. So here we see the corpus luteum, and here it's degenerated. There's the corpus albicans, a degenerated corpus luteum. When that occurs, there's a sharp drop in estrogen and progesterone, and the cycle starts all over again. If pregnancy does occur, then the corpus luteum will produce hormones to sustain pregnancy, estrogen and progesterone, but especially progesterone to sustain the pregnancy. And it will do that for about 3 months. At that point, the placenta takes over to maintain the embryo. So before puberty, the ovaries secrete small amounts of estrogen. And recall that when they're at low levels, when estrogen is at low levels, it inhibits the hypothalamus to release that gonadotropin-releasing hormone. But as puberty nears, so not there yet, a few years away, but as it's getting closer, the hypothalamus becomes less estrogen sensitive. So as puberty nears, also we need leptin levels to become adequate. Now you might be thinking back, where have you heard leptin before? And recall that leptin is secreted by adipose tissue, by fat, that regulates someone not having enough as far as appetite goes. We covered this in earlier chapters, but the body wants to make sure the female can support a pregnancy and have adequate storage of energy, fat levels, to support or sustain a pregnancy. So as puberty nears, and if leptin levels are adequate, which they normally are, well, then the hypothalamus suddenly becomes less estrogen sensitive. So if it's less estrogen sensitive, it can't inhibit as much, so therefore gonadotropin-releasing hormone is released by the pituitary, and we know this part here. It stimulates FSH and LH released by the pituitary, and then that acts on the ovaries, which we've went through in the ovarian cycle. So this will gradually increase for about 4 years or so until an adult pattern is established, which begins the first menstruation, which is menarche, first menstrual period. And then once that occurs, it takes about 3 years for cycles to become regular. So we know now leptin is important for the menstrual cycle to occur. So leptin plays a role in puberty. And adipose cells produce leptin, but adipose cells are also needed to convert adrenal androgens to estrogen. So adipose cells are extremely necessary, right, for a normal menstrual cycle. But menstrual cycles can be delayed in a young female or can stop in an adult female. Amenorrhea, which means without menstruation, or cessation of menstruation in adults, this can happen with very low levels of fat tissue. So a female who is perhaps a gymnast or a marathon runner, dancer, someone who is an athlete with very low levels of body fat can cause a delay in menarche or amenorrhea if they're an adult because of the importance of adipose cells and leptin for the menstrual cycle. So a lack of leptin can shut down reproductive cycles, but it can be reversed if the woman increases body fat. So young, healthy females can see dramatic bone loss like osteoporosis, usually seen in old age, if this homeostatic imbalance that we just went through here does occur.